Welcome to the lecture on observational study designs. This lecture is intended to provide additional detail about observational study designs. So during the overview of study designs, we learned about several different types of observational study designs. This lecture is going to focus on two specific types of observational study designs: cohort studies and case control studies. There are several learning objectives for this lecture, and they can be found on this slide. Of the analytical study designs, today's lecture focuses on observational studies. These studies differ from experimental studies in that we are looking at natural occurrences of exposure and disease without intervening. We're letting nature take its course. And there's certainly advantages to doing that. It would be unethical to expose people in a randomized controlled trial to a known harmful substance such as smoking. But in observational studies, we're able to look at the effects of smoking. Similarly, if we knew that a drug caused birth defects, we would not want to randomize patients to that drug, but based on use of that drug prior to that knowledge, we could look retrospectively or back in time to see how people were naturally exposed to that drug and then the consequences of that exposure. So observational study designs really allow us to look at exposures and outcomes that may be unethical with randomized controlled trials or difficult or time consuming. So lots of different reasons why we may want to use observational study designs. In addition, observational study designs can often help complement randomized controlled trials. So it complements how events occur in a controlled setting and looks at how they would maybe potentially occur in a real world situation. So often in controlled trial situations, patients come back or subjects come back at certain time periods and adherence is assessed, whereas in the real world that may or may not happen. And so we often see more realistic adherence patterns or medication taking behavior in observational studies than we would in randomized controlled trials. Cohort studies. These are the topics that we're going to review for cohort studies. Defining a cohort study. What are the key characteristics? How do we go about selecting study participants? How do we determine the exposure and the outcome? What about bias in cohort studies? And then lastly, the strengths and limitations of cohort studies. A cohort is a group of people who were followed over a period of time. This group of people often share a common experience or a common characteristic. It could be folks born in a certain year, Generation Xers. It could be folks that have had rhinovirus or the PharmD class of 2020 or geography, where folks live or reside. So again, different ways to different similarities for the groups and the different characteristic, but the group shares a common characteristic or a common experience. In a cohort study, participants are grouped according to their exposure status and then followed over time to compare the incidence of symptoms, disease, or death, or another outcome. So they must be free of the outcome or disease of interest, and we follow them over time in order to see when and or if they develop the disease or outcome of interest. There are different types of cohort studies, prospective and retrospective, that we discussed before, and the outcome may or may not be present when the study begins. So we'll talk a little bit more about that in the next slide, but it's important to know that the exposure precedes the outcome, but when the investigator gets involved in the study determines the type of cohort study it is. Cohort studies allow us to calculate the incidence of disease or the outcome, the disease rate or risk, and then we can compare the groups. We can compare the exposed and the unexposed groups using the measures of association we learned about, relative risk or odds ratio. So let's talk about the timing of cohort studies. So prospective, meaning to look forward in time. When the investigator gets involved in the study, participants are classified according to their exposure, whether it's present or absent, and then the investigator follows those people over time to see when they develop the outcome of interest. So at the time the researcher gets involved for a prospective cohort study, the exposure is known, but the outcome is unknown. Let's compare that now to a retrospective cohort study. In a retrospective cohort study, when the investigator gets involved, both the exposure and outcome have already occurred, but the subject participants are classified according to their exposure status, and then the outcome is determined, but both have already happened. They are both in the past. Again, exposure must precede the outcome, but the research at the time, the researcher isn't following the people forward in time to find out whether they developed. They may have already developed it. The researcher is investigating whether they have or they haven't. And a note here is whenever you're talking about studies and differentiating between retrospective and prospective, it's important to not just talk about a prospective study, but a prospective cohort study or a retrospective cohort study. So important that when you're defining the types of studies that you use the full name of the study, retrospective cohort study or prospective cohort study. So how do you determine whether to conduct a prospective or a retrospective study? So there's many different reasons why you would favor one design over another. There's practical issues of time and money, the availability of suitable study populations and records, and the decisions usually balance the advantages and disadvantages of the two types of study designs. Retrospective studies in general tend to be more efficient. They take less time and money than prospective studies. And also, for studies that have a long time for diagnosis, from exposure to diagnosis, retrospective studies, again, save years of having to follow patients over time to determine whether the outcome occurs. However, with retrospective studies, oftentimes the exposure is very far in the past, and there may be challenges with obtaining information to correctly define whether somebody has been exposed or to categorize the exposure variable. So that's, again, something important to consider when you're deciding between retrospective and prospective or evaluating those types of studies. Here's an example I want you to think about. So investigators want to assess the relationship between self-reported stress by students and GPA grade point average. So if investigators measure the stress level of P1 students at the end of their P1 year, and then a year later investigators obtain the student's GPA for the P2 year, is this a prospective cohort study or a retrospective cohort study? So if you said prospective cohort study, you would be right, because when the investigator gets involved, the stress level, the exposure is already determined, stress level of P1 at the P1 students at the end of their P1 year, but then the investigator follows students all during the P2 year to determine their GPA. So you have the exposure known, unknown or the exposure status of exposed and unexposed at the beginning, follow them forward in time to determine the outcome. So this is a prospective cohort study. Now, let's say if you looked at P4 students and went back during their P4 year and looked at their stress level in P1 and then their GPA in P2, that would be a retrospective cohort because the stress and the GPA have already happened. Again, the challenge here, though, is if you hadn't measured stress early on, it would be difficult in the P4 year to ask students to rate their stress in the P1 year, and that the accurate assessment of stress may be different based on what's happened in years 2, 3, and 4. And so again, that might be a reason why you would favor a prospective study to collect the data on stress and exposure early and then follow people over time, at least for this example. So an important variable here, unlike experimental studies where randomization often makes the treatment groups similar, right? That's the intent of randomizing to treatment A versus treatment B. In selecting the cohort, we try to minimize the differences in the exposed and unexposed groups except for exposure status. So it's important when we design methods and when you're reviewing studies to determine how they selected the cohort and did they minimize the differences or account for those differences. The challenge is that some of the differences that we worry about or that we know about are able to be considered, but it's the factors that we don't know about, that we don't account for, that really can influence the study results in these types of studies. So again, important to try to minimize the differences in the way you design the study, except for the exposure status difference. We also want to make sure we have sufficient numbers to be able to detect a difference if a difference exists between the two study groups. So when you're determining exposed and unexposed, there's important things to consider is what information do you have available to decide exposure? And then how do you classify that exposure? So for example, let's take smoking. If someone smoked, if you asked if you ever smoked, that could be a yes or a no. Have you ever smoked? So you could say exposed is ever smokers and unexposed is never smokers. But the level of exposure or the level of smoking might be important. So what if somebody had a cigarette one time in their life? Is that the same as somebody who smokes 3 packs a day? So we might want to categorize that level of exposure. Let's think about this in medication related terms. So when we look at studies that often look at the use of a drug, so we want to look at people who use drug A versus drug B and then look at their outcomes. Do we look at patients if they got one prescription for that medication? Do we require 6 months of use? And so it's important to determine what information do you have available to decide upon exposure. So for the refill information, are we asking the patients, did you ever take this drug? Yes or no? Are we looking at claims data or refill records from a pharmacy where we can see patterns of at least they picked up the prescription? Again, there's pluses and minuses to both of those information sources. So the claims data just tell me whether the patient got that prescription, picked it up. It doesn't tell me whether they took it. Self-report may, the patient is telling you whether they took the medication or not. And again, there may be some challenges with self-report. So there's different information sources give you different levels of exposure, right? Different types of exposure, different decisions about the exposure. And then the investigator has to think about categories of exposure, whether any fill, one tablet once is the same as taking it for a certain duration of time. So again, very important when you're looking at exposure and how the investigator categorized and classified the patients who are exposed and unexposed to look at some of these factors on how that was determined and classified. Same thing with outcomes. So how did we determine the outcomes? How long did we follow patients? Let's say you're looking at whether somebody has a hip fracture and you're looking at a drug and you look whether they got the drug or they didn't get the drug and then whether they had a hip fracture. Well, depending on the age, if you're looking at 20-year-olds who took drug A versus drug B, you might have a long time to wait to get enough data to determine whether there was a risk of hip fracture or an association of hip fracture. So it's important to think about what outcome you're looking at, how long follow-up should be, what information is available. So do you ask patients whether they had a hip fracture or not? That might be pretty reliable. I would think a patient would know that. What if we're looking at an elevated level for a laboratory test? Let's say we were looking at a drug and looking at whether it elevated abnormal liver enzymes. Would the patient necessarily know that? Or would you need laboratory results? And then how often would you need those results? And how many times would you need it to be elevated to consider that outcome happening? So again, thinking about how long should you follow up patients, what information are you using to determine whether the outcome occurred, and then again, how do you classify that outcome? So with many of the decisions you make in cohort studies, there's a potential for bias. So bias is a systematic error that results in an incorrect estimate of the measure of association. It can occur during design of the study, during data collection, when you're analyzing the data and/or when you're publishing the data. And we can avoid bias or minimize it by carefully designing and conducting the study. So we're going to talk a little bit more about bias. There are two types of bias in cohort studies: selection bias and information bias. So these are two big categories of bias, selection and information. We'll talk about those separately. So selection bias occurs when the way that you select study participants and the way that factors influence participation, if there's a systematic way that selection has occurred that influences those factors. So for example, the two selection bias issues that we worry about in cohort studies are loss to follow-up and the healthy worker effect. So loss to follow-up occurs when study participants can no longer be located or when they no longer want to participate in the study. And loss to follow-up can be very problematic. It can be a big concern. It can reduce the power of this study to detect associations that are truly present. So in other words, detect a difference if a difference exists. Again, if you lose people to follow-up, the sample size is now smaller that's available for analysis, and it can bias the study results. Now, loss to follow-up, there can be non-differential and differential loss to follow-up. So non-differential loss to follow-up refers to when you lose subjects either in the diseased or the exposed, but they're unrelated to the other axis. So one axis of disease or the exposure, or the other axis of disease or exposure. So they're not related to each other. It's just losses on one side of that equation. So for example, if you lose an equal number among the exposed and unexposed individuals that have the disease, that's non-differential loss. You lose the same number of diseased individuals among the exposed and unexposed groups. Now, differential loss is when the losses are related to both the exposure and the disease. So when you're more likely to lose patients with the disease among the exposed individuals than among the unexposed individuals, that is a differential loss to follow-up. And both of these classifications of loss to follow-up can have an impact in many different ways. So whether or not they bias the results depends on whether you're looking at an absolute or relative measures of association, and whether the losses are non-differential or differential. So it's important to think about some of the ways that bias can occur for loss to follow-up and how they can impact the results. So for example, if you're looking at the relative measure of association, it won't be affected if you have non-differential loss to follow-up, right? In other words, the same amount of people, equal losses of diseased individuals among the exposed and unexposed. So the relative measure of association won't be affected. However, the absolute will be affected, and it will result in the observed disease incidences that are actually lower than the true incidence because we're losing people. Again, so the absolute changes, but the relative does not change. Now, when we think about differential loss to follow-up, it can bias both the relative and the absolute measures of association, but it can go either way. It can go upward or downward depending on whether the loss occurs among the exposed subjects who develop the disease, or it occurs among the unexposed subjects. So it can affect, it's not one direction only. It can bias them, again, different directions depending on where the loss to follow-up occurs, preferentially in which group, right? In other words, where the losses are greater in one group versus the other. I think in general, it's difficult to really determine, especially when you're reading a study, if the losses are due to differential or non-differential, because the outcome information is really unknown for these subjects. So we don't know whether it's differential or non-differential loss. So I think just with that in mind, it's really important to maintain high and similar follow-up rates for the two groups that are being compared, the exposed and unexposed. So something to think about when you're evaluating studies. The other bias to consider is the healthy worker effect. And the healthy worker effect occurs in cohort studies because the general population, so if you're comparing, the general population consists of both the healthy and ill people, right? So if you're comparing that to a relatively healthy working population, you will bias your study results. So for example, let's say you have a group of people who are working, that get sick and no longer work, if you're comparing the people who are working who are not sick, right, because the sick people are no longer working, to the general population, there will be more diseased people in the general population than in the healthy worker population. So again, a type of selection bias in a cohort study. The other big type of bias is information bias. We talked about selection bias. Now we're going to talk about information bias in cohort studies. So information bias is due to faulty methods used to measure an exposure or an outcome that results in different quality of information between the exposed and the unexposed groups. So there's three types of information we're going to talk about in cohort studies: recall bias, interviewer bias, and misclassification. So recall bias occurs when there's a differential level of accuracy in the information provided by the compared groups, the exposed and unexposed groups. So let's say in a cohort study, if exposed subjects are more or less likely than unexposed subjects to recall and report subsequent diseases, that would be recall bias. I just want to take a minute here to differentiate recall bias from poor recall. So poor recall implies that there's a similar level of inaccuracy among groups. In other words, both groups just have a difficulty time with recall, poor recall, and that you have equally inaccurate results for both the exposed and unexposed groups. That would be maybe poor recall. Recall bias is when there's a different level of accuracy in the information provided by the exposed and the unexposed groups. So let's say, for example, people were taking, you had exposed people taking drug A and unexposed who didn't have drug A. If there was a media report that came out that said drug A caused X, there might be different recall, right? It might be recall bias because the people that took that drug are maybe looking for that disease more so and recalling information about the disease more so than people who didn't take the drug. So again, that's how recall bias would be different between the exposed and unexposed groups. So interviewer bias, another type of information bias, is a systematic difference in soliciting, recording, or interpreting information that occurs in studies using in-person or telephone interviews. So again, let's use the same situation that folks drug A exposed and group B unexposed. Let's say the interviewers knew that drug A caused or was associated with a disease. They might interview or query or probe more deeply if they knew that the folks that they were interviewing were exposed to that drug. So a way to minimize that is to not let interviewers know whether the individuals they're talking to are in the exposed or unexposed group, and also to potentially, not share the hypothesis that you're looking for. So you have them ask a lot of questions on a lot of variables so that there's less tendency toward interviewer bias because they're treating exposed and unexposed groups differently. So the last type of information bias is misclassification, also really called measurement error, and it's probably the most common form of bias in research, in observational research. So misclassification means that there was an error in the way that you classified either the exposure or the diseased. So if you said that the individual was exposed when they weren't, or vice versa, that is a misclassification. It also can occur when you say that a person has a disease or they don't. So let's say we rely on patients to tell us whether they had an elevated abnormal liver enzyme. Again, if we were relying on patient self-report, we might misclassify patients and say that they had an abnormal LFT when they did, or say that they didn't have one when they really did. So that would be misclassification of exposure and or misclassification of disease. So like loss to follow-up, there's two types of misclassification: non-differential and differential. So again, differential misclassification refers to when there's errors on just one axis, the exposure to or the disease, and they that are related to the other axis, exposure or disease. So that's differential misclassification. Non-differential misclassification refers to errors on one axis, either the exposure or disease, but they are unrelated to the other axis. So, for example, if you misclassify exposure, it occurs with equal likelihood among the diseased and the non-diseased individuals. So we talked in the example a little bit about ways, so to minimize misclassification, it might be the type of information or the data we collect. So instead of relying on self-report for abnormal liver enzymes, we would get laboratory data that had the exact levels of the liver enzymes reported on that lab work. So let's spend a little time talking about the strengths and the limitations of cohort studies. So for cohort studies, we can calculate the incidence of the outcome or the disease in the exposed and unexposed individuals, right? We know that the exposure precedes the outcome, and we are looking for new incident cases of the outcome or disease because the individuals to be in the cohort study cannot have the disease at the outset of the study. We can also look at multiple exposures and multiple outcomes for cohort studies. If we're looking for rare exposures, we can look at cohorts that actually have those known exposures. So it can help us when we're looking for rare exposures to follow those people over a certain period of time. We also, especially with retrospective studies, can have a lag time between the exposure and the outcome or the disease, unlike a prospective controlled clinical trial where we start randomizing patients and exposing them to treatment A versus treatment B and then following them. A retrospective cohort study could have a long lag time between the exposure, it could be 20 years ago, and the outcome of the disease, which could be in the present, or it could have even been 5 years ago. So there could be a long lag time between the exposure and the disease. There is less potential for bias compared to case control or other observational designs. And when we compare cohort studies to randomized controlled trials, a couple of advantages. The generalizability may be better. Again, randomized controlled trials are artificial clinical controlled settings where we're randomizing patients to treatment. We're following them in ways that we traditionally don't do in the real world. And we oftentimes have very strict inclusion and exclusion criteria. So the results, again, may not be generalizable to the larger population that has that exposure. And they're also less costly than randomized controlled trials. So two advantages here of cohort over randomized controlled trial. And again, less potential for bias compared to case control or other observational study designs. So there are also a few limitations of cohort studies. They are more costly and time consuming than case control studies. And again, because we're following participants forward in time, actually for prospective, there's a higher potential for loss to follow-up. Case control, we've got the cases and controls defined, and exposure and outcome obviously have already happened at that time. So there's a much higher potential for loss to follow-up with cohort studies, and especially prospective cohort studies. They're less suitable for rare outcomes or diseases. So again, with a case control, which we'll talk about in a second, we're able to look at rare diseases and outcomes more successfully with that type of study design than with a cohort study. And then there are the potential for selection and information bias in cohort studies. So the next type of observational study design are case control studies. The key topics we're going to discuss for case control are defining a case control study, key characteristics, selecting the cases and the controls, bias in case control studies, and then lastly, the strengths and limitations of case control studies. So case control study, it's a method of sampling a population in which researchers identify and enroll cases of the disease, i.e. the cases, right? And a sample of the source population that gave rise to the cases, the controls, but they do not have the disease, right? So we're looking at a population of patients. We've got people that got the disease, they become cases, and then we've got people that didn't become cases, and they are the controls. When you think about it, it's somewhat similar to cohort studies in that we have people that get the disease and do not get the disease, but it's where the researcher intervenes and where the way that they select the cases and controls is different versus the observational cohort where we're looking at people based on exposed and unexposed. Here we are looking at people with disease and non-disease. So a couple of key characteristics. Study participants are identified by the outcome status, right? They have the disease or no disease at the beginning of the investigation. And it's a very practical study design. We mentioned earlier when outcomes are rare or disease is rare, the exposure data are difficult or expensive to obtain. And so we don't want to have to get a lot of data on people and then follow them over time, especially when the outcome may not be very common. There is also a benefit of case control design when the disease has a long lag period between the outcome, between the exposure and the outcome. So here we've got people that have the disease and they don't have the disease, and we can go back in time and see whether they were exposed or unexposed. Again, it helps address that, somewhat similar to retrospective cohort studies. How we compare the groups, the exposed and unexposed groups, is we use our odds ratio to compare the groups. So here in this study design, the researcher at the beginning determines whether people have the outcome, present or absent, and whether they are exposed or unexposed. So they're going to find an exposed and unexposed group in those that have the disease, and they're going to find an exposed and unexposed in those that do not have the disease. And that's different than the cohort studies where we have people that are exposed. We're going to have people exposed, and then we're going to have people that have the outcome and don't have the outcome in the exposed group. And in a cohort study, we're going to have people that are not exposed, unexposed, that are going to have the disease and not the disease. So we're looking kind of at 4 different groups: exposure with disease, exposure without disease, but the way that we're looking at them is different depending on whether a cohort, we have the 2 groups that we break into the 2 groups based on exposure for cohort studies, whereas in case control, we have the 2 groups that start with the outcome, present or absent, and then we break those into 4 groups with the unexposed and exposed if they have the disease, and the unexposed and exposed if they do not have the disease. So cases are those with the outcomes of interest. So for example, somebody's diagnosed with a disease. The outcome could be hypertension. It could be that they had a procedure, a CABG, cardiac bypass surgery, or they had an adverse event, a seizure after using varenicline. Cases can be either incident or prevalent cases. Incident cases are new cases, usually based on the time of diagnosis. And again, as we talked about, for some diseases, the onset may be long before the diagnosis. So somebody could have, just because somebody gets diagnosed with diabetes last year, doesn't mean that's when they first developed diabetes. They could have had it for 10 years and not been diagnosed, not sought medical care, not had a test that helped determine diagnosis. So just important to think about that concept when you're evaluating studies and how they're determining diagnosis or disease presence or absence. And then, as always, the measurement of exposure should precede the disease onset. Again, as we start to move away from randomized controlled trials to prospective cohort studies to retrospective cohort studies to case control studies, it's always important that the exposure precedes disease onset, but we become less confident that that is always true as we progress from each of those study designs. Now, prevalent cases are all the cases. So they could be new and old cases, right? Existing old cases, but they're prevalent. They could also be new. So it's all the cases, really, is prevalent cases. They overrepresent folks that didn't die from the disease, so maybe a survivor bias, right? Or those who did not recover from the disease. So again, it may present a different type of severity of the disease when we look at prevalent cases. And it may really be, instead of an exposure-disease relationship, it may be an exposure-duration relationship when we look at prevalent cases. Subjects less likely to remember exposures, again, that might be poor recall versus recall bias, which is differential recall in cases versus controls, but just something to think about it. It could be differential as well. It's more difficult to establish the timing of exposures relative to the disease onset. So again, we prefer incident cases when possible. So when we're selecting cases, we want to have a clearly established definition of the disease and diagnostic criteria before we start the study. So we want inclusion, exclusion criteria to applied to ensure that the cases are homogeneous. We want to have a clean, clear definition. When you start to look at case control studies, this is often a point that's very important to discern whether the design truly identified those with the disease. And you'll see for certain diseases it may be very clean because that diagnosis or that disease or that laboratory test is very specific for that outcome that you're looking at. But there may be others that do not lend themselves well to determining whether the person has the outcome or not. So for example, in the pharmacy world, when we just look at pharmacy claims, a lot of times folks want to use a drug or a medication claim to proxy a disease. So if you think for insulin, potentially the use of insulin, you would say maybe that's a fairly good proxy for somebody that has diabetes, because we don't tend to use insulin commonly for people that have other disease. It's not perfect, but it may be pretty good. However, when you look at an antihypertensive, when you say, okay, if they're on an antihypertensive, they have hypertension, that's probably not a good proxy because antihypertensives can be used for people that have migraine headaches. They can be used for people that have stage fright or performance anxiety. So the antihypertensive is not necessarily a good proxy. So again, very important to define the disease or the diagnostic criteria, and when you're evaluating studies, to ensure that that is really an accurate way that we would know that that person had the disease. You don't have to identify all the cases. The cases must be representative of the cases in the target population, the cases that are selected, and the cases can be from various sources. So what are these sources? We could get data from people who are hospitalized, hospital data, or clinics, patient care, outpatient records. There are disease registries for folks, especially if you're looking potentially at rare diseases. There are screening programs that you could look at if people went and had a certain laboratory test to determine, let's say you wanted to look at prediabetes. Potentially you would want to look at some screening programs that screen for prediabetes. And again, we talked about the preference of incident cases to prevalent cases and the overrepresentation of survivors with prevalent cases. So when you're selecting controls, they must come from the same source population as the cases. Controls are a sample of the population that produced the cases but do not have the disease, or at least not yet. They can also be called the referent group, and controls may become cases later on. And the controls will give the expected rate of exposure if there's no association between the exposure and the disease. So an important point with the control group in a case control study. Now, selecting controls can be challenging, and selecting cases and controls in general is one of the most challenging aspects of designing a case control study. The controls must be sampled independent of the exposure status. So we don't want the exposure status to be influenced by how controls, because that would cause bias in the study. We can use more than one control group, and so we may want to look at different control groups, because if you find similar results using different control groups, that gives you more confidence in that result. And then we can also have multiple controls per case. So it doesn't have to be a 1-to-1, a 1 case to 1 control ratio. We could have a 1 case to 3 control ratio. And multiple controls actually increase the power to detect a difference, given a difference exists. However, that doesn't mean you can have 10 controls. So there's an advantage of maybe 3, maybe up to 4 controls per case. But once you go past that, then you start to get into additional problems. But multiple controls per case can be very helpful, especially when you've got a rare disease with few cases. So where do we find controls? General population is preferred, right? So if we're comparing the cases, if we're looking at a hospital population as our control group, that might not be good because people that go to hospital may or may not be may be more likely or less likely to have the exposure, depending on what the exposure is. You could have friends or relative of cases. And then the controls should have the same underlying conditions as the cases. Again, we want to try to make them the same population. The controls are representative of the population in which the cases arose. So as in cohort studies, determining the exposure and the outcome, very important. The outcome here in a case control is decided by determining your cases and your controls, but then we need to look back in time to determine the exposure. And to help prevent some bias in our measuring and determining exposure, we need to have a standardized data collection. We want to collect the data in the same way for the cases, the same way for controls, and we want to establish a temporality, right? We want to ensure the exposure happened before the disease. So very important in the ways that we collect exposure and the information sources that we use are very important when you're evaluating a case control study. So similar to cohort studies, there's two types of bias, a selection bias and an information bias, and several different types of bias within each of those main categories. So selection bias, again, occurs due to methods used to select study participants and factors that influence participation. So there's different selection bias in case control than there are in cohort. So in the case control, we have control selection bias, we have a self-selection bias, and then we have differential surveillance, diagnosis, or referral. So three types of selection bias in case control studies. So control selection bias occurs when the way that you selected the controls is different based on their exposure status. So for example, let's say you have cases that have a disease and you are looking for controls. They do not have the disease, and you get the controls from a physician's office. And we're looking at whether they had drug A or drug B, or they received screening A or screening B. If we are looking at folks who are being seen at the physician's office, they are more likely to have screening than the general population. So if the cases, the folks with the disease, had, were not solely from physician offices, they were some who from physician office records or not physician office records, or they didn't get exposure until they got diagnosed with the disease, they weren't in the medical, you're choosing controls that have a differential exposure, right? Because if you're going to regular routine care, you're more likely to have preventive care, screening is recommended, and more likely to have screenings in the general population. So control selection bias is really how, when you select your controls, their exposure status is different in the way that you selected them compared to the cases. And that's very important because we're looking at the exposure, exposed and unexposed, in those with the disease, cases, and the control group. So case control studies that have low or moderate participation rates are susceptible to self-selection bias from folks that refuse to participate or non-response that is related to both the exposure and the disease. Or folks that maybe agree to participate that's related to exposure and disease. So it doesn't just have to be that they don't participate. It could be that they do participate. In other words, the fact of self-selection differs related to their exposure and their disease. So the best way to minimize self-selection is to have high participation rates among both the cases and the controls. And again, we often don't have the data for the folks that don't participate, but it's important when you look at rates. If they asked they asked 100 people and only 20 people participated, there's a large non-response rate in that. And again, important to look at in the cases non-response rate and the controls non-response rate. So the last type of selection bias in case control studies that we're going to discuss is differential surveillance, diagnosis, or referral. So when there are differences in these aspects that's related to the exposure, that can affect case control. That can affect your interpretation of the results. So for example, if we're looking at folks that use oral contraceptives and we're looking at blood clots, if we're only looking at folks that were hospitalized for a blood clot, and we look at folks that were hospitalized for an acute illness at the same time, we might have differences here because folks are aware, clinicians are aware, may have a high index of suspicions because we know that oral contraceptive use increases the risk for blood clots. So if there's a differential likelihood to be admitted to the hospital because of the physician's knowledge that the woman was an oral contraceptive user, that can affect, right, differential surveillance, differential diagnosis, differential for referral. You're going to handle a woman on an oral contraceptive differently than a woman who is not on an oral contraceptive. So again, when you select your cases and your controls, that is important to consider the patterns of use surrounding the disease or diagnosis that can affect the way that we care for patients, and then obviously the way we analyze or look at the research of natural patterns of care. So information bias in case control studies, again, due to faulty methods used to measure an exposure and outcome that results in different quality of information between the exposed and unexposed groups. So these are the same, these three, recall bias, interviewer bias, and misclassification, these are the same in case control studies as in cohort studies. So lastly, let's talk about the strengths and the limitations of case control studies. So case control studies in general are less costly than cohort studies. They're useful for rare outcomes and diseases particularly, or in the early stages of research when we're not sure about a particular exposure disease association. So again, helpful. They're less costly, they're usually faster to perform, and you can have a smaller sample size because you're starting with the people with disease and non-disease groups. What about the limitations? So there's a few limitations. The exposure information may be unavailable or inaccurate, and the temporal relationship between exposure and outcome may be less, you may be less confident in a case control study than you would be in other types of study designs. You can't estimate incidence, and therefore you can't estimate relative risk. And that's why our measure of association is odds ratio for case control studies. And similar to cohort studies, there's a potential for selection and information bias, although their types of bias is a little bit different between case control and cohort studies. So in summary, observational study designs require investigators to select participants carefully. The information on the exposure and the outcome disease can be obtained using many different methods. Observational studies can be limited by selection and information bias, and then cohort and case control studies are useful in very different scenarios, and they have different strengths and limitations. And this concludes the lecture on observational studies.